Oh, is it my time? I feel like
It is.
it's
Yeah,
your
it's your
time.
time. It's your time.
This paper published in JAMA in July of this year. So out of UAB, basic champion, a more selective versus standard risk stratified heparin-based obstetric prophylaxis protocol. So some of you might remember hearing this topic. I think it was abstract three, number three, maybe. It was in the opening oral plenary session at SMFM this last year. It was presented by the first author, Maisie Champion. She's out of UAB. And their objective was to evaluate outcomes of a more selective risk stratified approach to heparin-based obstetric thromboprophylaxis with enoxaparin through a change in protocol per institution. So VTE, it includes venous thrombosis, pulmonary embolism. It's estimated to occur in about 1 to 2 per 1,000 deliveries. Pregnant and postpartum patients have about a 4 to 5-fold risk of VTE compared to their non-pregnant counterparts. VTE is responsible for about 10% of maternal mortality in the last 2 decades. That's been relatively stable. And then although pregnant patients remain at high risk of VTE throughout pregnancy and the postpartum period, the risk is really the most significant within the first week of postpartum. And this is due to many things, but just at baseline, pregnant patients have a different physiology. So they have a hypercoagulable state, increased venous stasis, compression of the IVC, and congestion of the pelvic veins as the uterus enlarges, as well as decreased motility. There are certain pregnancy complications that can further compound this risk, and that includes surgeries like cesarean delivery, cesarean hysterectomy, especially if surgeries are accompanied by infection, postpartum hemorrhage, or other comorbidities such as hypertension, preeclampsia, cardiac disease, sickle cell disease, nephrotic syndrome, diabetes, and then multiple gestations. So we probably all know this too well, but ACOG, SMFM, RCOG, and the ACCP, they all recommend using these risk factors to create a risk stratified approach to guide appropriate utilization of postpartum chemoprophylaxis, but the overall guidelines are really based on expert opinion and not on RCT data, because it is extraordinarily hard to study such rare outcomes. And so each, institution tends to have their own protocol for postpartum chemoprophylaxis. And then to understand this study, you really need like a brief history of the anticoagulation guidelines or lack thereof at UAB. So prior to 2016, UAB left the postpartum enoxaparin protocols up to the discretion of the provider. And in this study, this is referred to as the no anticoagulation guideline. And then during 2016, UAB adopted a risk stratified protocol for postpartum Lovenox that created a more standardized approach. And then this is referred to as the original protocol. This bears great similarity to our protocol as it stands right now. Yeah, and I imagine a great similarity to a lot of different institutions, teaching institutions. So after they made this protocol change, this was retrospectively analyzed by Michelle Liu et al. Out of UAB, looking at differences in wound hematoma and VTE rate using a very similar methodology as this paper. They reported an increase in wound hematomas, unplanned surgeries, and blood transfusion without a decrease in VTE in response to this protocol change. So this Liu paper is referred to a lot in this paper because they're very similar. Michelle Liu
that was the data for their
and their original data set for the regarding the original protocol. So in response to the Liu paper, UAB changed their protocol yet again to adapt a more selective approach in 2021. So this is now referred to as the selective, but a more selective protocol. So this study published in 2023 compared the frequency of postpartum bleeding complications in VTE between the original and the selective protocols implemented at UAB. They do also do a comparison between the no anticoagulation and the selective protocols as well. So brief part of the results. So they performed a retrospective observational study analyzing outcomes in patients who delivered at UAB between January 1st of 2016 and January 31st of 2018. That is the original protocol group. And then between December 1st of 2021 and May 31st of 2023, which is the selected protocol group. Deliveries were categorized based on the time of delivery. So anything that fell within the original protocol timeline was in the original protocol, and anything between in the selected protocol was put into the selected protocol. And all patients who delivered at UAB during both timeframes were included in this analysis. Patients receiving outpatient anticoagulation, either prophylactic or therapeutic, were excluded. And then the years 2019 and 2020 were not included in the analysis. The reason for this is because the many clinicians were beginning to react to the data presented by the Loop paper. And there were no new institutional protocols formalized yet at UAB. And they were still trying to work through how to respond to that data. Conveniently, this overlapped with the beginning of the COVID pandemic. So when there were a lot more plots, presumably. But regardless, we continue. The institutional postpartum order set is just like ours. So when a patient becomes postpartum, you get prompted to put in postpartum orders. I think most people have done this. And you'll get met with a pop-up of prompting you to select the appropriate anticoagulation regimen for this patient. That's usually based on BMI, and then it's based on additional risk factors. And that dictates whether or not they're appropriate for chemoprophylaxis and what dose is appropriate. This, prompt through an EMR order set, they report in their paper has a 95% compliance. I imagine we also have very high compliance for this, as you can't actually place the orders for postpartum without going through this. So patients meeting criteria for enoxaparin, this is also pretty standard, had enoxaparin initiated on postpartum day 1, no sooner than 6 hours following a vaginal delivery, 12 hours following a cesarean delivery, and this was continued through their hospital discharge. Patients with a BMI lower than 40 received a 40 milligram dose daily. Patients with a BMI of 40 or greater received twice daily, 40 milligrams. And then anticoagulation was not initiated within 12 hours of epidural placement or 4 hours of removal, whichever is longer, to decrease the risk of epidural hematoma. So this table demonstrates the differences between the original selected 2016 and the revised thromboprophylaxis protocols. And I highlighted some of the major changes between each protocol. So patients in the original protocol group received enoxaparin if they had a pre-pregnancy BMI of 40 or greater, a history of VTE, high or low risk thrombophilia, or 2 more additional risk factors, which I'm referring to as minor risk factors or medical conditions. And then patients with the more selective protocol group, so this is the 2021 and beyond group, received enoxaparin if they had a history of VTE or nephrotic syndrome. So nephrotic syndrome is upgraded to a major criteria, but required 3 or more additional risk factors to meet criteria for anticoagulation. So although BMI was still considered a minor risk factor, it was no longer an independent indication for enoxaparin in the more selective protocol. And in addition, age over 40 was no longer considered a minor criteria in the more selective protocol. Higher order multiples were added as a minor criteria. SLE required 2 medications to be considered a high-risk medical condition. Nephrotic syndrome was upgraded to a major criteria, and then a urine protein to creatinine ratio over 3 was added as a minor criteria in the more selective protocol, which captures many of our preeclamptic patients, or all of them. And then a major infection was changed to be specifically sepsis. So for their methods, both components, okay. Both components of the primary composite outcome were manually extracted through individual electronic medical record review, while clinical imaging operative notes, baseline characteristics, self-reported race, ethnicity, and other remaining outcomes were obtained from a combination of chart review and then coded data extraction. They went through over 17,000 charts in this study period. So they compared outcomes between patients who delivered in the time of the original protocol, like I said, 2016 to 2018, and those who delivered during the time of the more selective protocol, 2021 and 2023. The primary outcome they were interested in, much like the Liu paper, was a clinical diagnosis of postpartum wound hematoma occurring from after delivery through 6 weeks postpartum. Secondary outcomes of interest were new postpartum VTE, time from delivery to VTE diagnosis, similar safety outcomes, as well as a composite postpartum wound complication outcome, which looked at infection and non-infection complication of the surgical site or perineum. Their statistical analysis, so they looked at differences in baseline characteristics, primary outcomes, and secondary outcomes between groups using where appropriate chi-squared test of association, Fisher exact, or categorical for categorical variables, and t-tests or Wilcox-Rank sum tests for continuous variables. Each pregnancy was treated as an independent observation, given that VTE risk factors and criteria for anticoagulation could vary between pregnancies. They did something called backward selection on the primary outcome to generate a parsimonious regression model using patient characteristics identified as statistically significant between groups. They also use multivariate logistic regression models to estimate odds ratios with a 95% confidence interval, and tests of interaction were used to address differential effects of the guidelines on the primary outcome based on mode of delivery, cesarean versus vaginal delivery, obesity. And then they use propensity score matching between patients in both study periods. So the group also planned a comparison of outcomes, not just between the original and the selective groups, but also between the selective group, which is the 2021 and beyond, and the no anticoagulation group, which was the pre-2016 group. They also plan to compare outcomes between the selective and the original protocol groups and those who did actually receive anticoagulation, rather than all patients, which would include those who did not and those who did. In the study by Liu et al., the wound hematoma frequency was about 0.7%. With the implementation of the original protocol compared with a 0.4% prior to 2016, which was with the no anticoagulation guidelines. So using that knowledge, this group estimated a return to a baseline wound hematoma rate of about 0.4 in the more selective protocol, so going back to the pre-2016 rate, than what was observed in the more original protocol of 0.7. So they calculated an 80% power to detect a 50% reduction in the hematoma frequency in the more selective group compared to the original group. So over 17,000 patients delivered during the study period, and of these, 2% or 357 were excluded due to use of outpatient anticoagulation. So 17,489 were included in the study, 12,430 or 71% were included for the original protocol period, again, 2016 to 2018. And then the remaining 29%, 5,059 were included during the selective period, which is 2021 to 2020. During these periods, 19,036 received anticoagulation, and over 10,000 did not for the original group. And then 427 received anticoagulation in the selective period, and over 4,000 did not in the in the original group, and then that's for the selective group. So overall, the selective group was just a smaller group of people. And then in the original protocol, 90 patients or 0.7% had wound hematomas and 0.1% had VTE. And then in the selective group, 17 or 0.3% had wound hematomas, and a similar rate of VTE was observed at 0.1%.
Let me add that some percentages. So in the first group, 16% received anticoagulation. 1936 divided 12.30 is 16%. And 427 divided by 5,059 is 8%. So they went from 16% in anticoagulation to 8%. So yes, half of them.
Have that, which is
and interestingly, how they also have more than half the incidence.
It looks. I wish they had done a third group where the patients were qualified in the first original protocol, but did not receive the anticoagulation and see what happened, because that is actually the question. Patients who would have been candidates for thromboprophylaxis that did not receive it due to a more selective protocol, what happened with them?
Oh, I see. Yeah.
Did they increase the risk
like
of
they
thrombosis?
they put them into a new group.
Yeah, like to be safe that those patients, which are about a good 1,000 people, did not receive anticoagulation at all, but they seem not to report those cases.
They do that, right?
Wait. I mean, the rate of VTE is among out of everyone.
Yes,
you
but
mean looking
they are,
I see what you
yeah,
mean.
but the original protocol, let's say, included everybody, but now they're more selective. So I want to know what happened with the ones who were not selected.
Like who had those 4 VTEs?
Exactly.
Were they in people who did not have?
Did they have what
were their risk factors? Yeah,
It could have been like that group that was excluded had a triple time of DVTs, and they were not included. So it's a very important limitation of the study.
So they talked about the differences between their groups as well. So the original versus selective groups, they were significantly different in multiple characteristics, including age, self-reported race, insurance status, ethnicity, marital status, pre-pregnancy BMI, and then the presence of comorbidities, all of which are factors related to VT. And then specifically patients in the more selective protocol group were older. They were less likely to have government funded insurance. They had a higher BMI. They were more likely to use aspirin, as that was becoming popular as a recommendation. They were more likely to be diagnosed with preeclampsia, 21 versus 16%. And as Dr. Bergello pointed out, 8% received enoxaparin in the selective group and 16% received it in the this is our table 3. So this demonstrates the primary outcomes and secondary outcomes between the original and selective protocols. So this table demonstrates a reduced rate of any hematoma between the two groups, 0.3% versus 0.7%. The more selective protocol was associated with a reduced rate of wound hematoma in both univariate and multivariate analysis, and this was driven largely by a 50% lower rate of superficial wound hematoma. You can see that 76% in the original, or 76 patients, 0.6% in the original protocol, and 15 patients, or 0.3% in the more selective. There are secondary outcomes also presented in this table. So the more selective protocol was associated with fewer wound complication, outcomes of any kind. But compared with the original protocol, the selective protocol did not differ significantly in rates of VTE or individual frequencies of DVT or PE. And that really is listed here. This is some of their supplementary materials, so additional secondary outcomes. They found no difference in unplanned procedures, estimated blood loss, receipt of uterotonic medications, transfusion of overall blood products, postpartum resource utilization, but they did find a difference in utilization of factor blood cells, which were higher in the original group. They also compared primary and secondary outcomes based on mode of delivery. So patients who underwent cesarean delivery during the more selective protocol time period, about 1,700 of them had a significantly lower odds of wound hematoma compared to those undergoing cesarean delivery with the original protocol. There are about 4,000 of those patients, and the odds ratio was 2.1 versus 0.6. Wound hematomas amongst patients who delivered vaginally were not significant by any group, and there was no significant group difference in VTE diagnosis amongst those who underwent cesarean versus vaginal delivery. These are the primary and secondary outcomes stratified by mode of delivery. There were no significant group differences in any wound hematoma, superficial wound hematoma, or deep wound hematoma. That is demonstrated in this group. When you look at this is the primary and secondary outcomes between the no anticoagulation group, which is the pre-2016 group, and the selective group. So they're highlighting that they have very similar outcomes. It's when you allow clinicians to decide when anticoagulation is appropriate versus a selective. So in their discussion, they highlight that, there's multiple sources they talk about, but chemical prophylaxis is certainly beneficial in reducing VTE risk in high-risk patients, but the challenge is choosing the appropriate low risk appearing patients to also receive chemical prophylaxis without causing harm. So safety of broad use in low risk patients is questionable, and it can lead to high rates of wound complications and hematoma without significantly lowering the VTE risk. They are quite dismissive of large future RCTs and saying that they're not feasible. And that I think, I think because this is a very rare outcome, VTE is generally rare and difficult to study, but they were basically like, it's not possible to do RCT. But they do recommend that future work evaluate chemoprophylaxis guidelines to determine the utility and safety of routine use, even in populations at higher risk of postpartum VTE, and that we evaluate the safety of newer oral anticoagulants in the postpartum period, including lactation, as potential alternatives to heparin-based prophylaxis. And I must agree. The strengths of this study, so it was a large patient population receiving care in a group care model, which kind of standardizes plans of care and decreases variability in guideline implementation. There were no institutional changes in how they evaluated clinical wounds or management over the study period, so that might affect misclassification or recall bias. And then primary and safety outcomes were abstracted from the charts using individual chart review as opposed to use of ICD-10 codes, which can contribute to misclassification. And then this study was demographically, socioeconomically, and medically diverse. Some of their listed limitations were that this was, of course, retrospective and can't fully address confounding variables. Differences noted in baseline characteristics, like I pointed out before, are known to increase VTE risk. So the fact that their two groups were significantly different, things like age and preeclampsia risk are notable differences. And then their high-risk population referral center, so UAB is more likely to receive patients with wound complications, but that would presumably apply to both of the groups. So the 2016 population and the 2021 population, it may not significantly impact the results, but they do acknowledge that they may miss patients' follow-up complications because they're more likely to present locally rather than be referred back into middle of the state. This is also performed at a single institution. While UAB is a fabulous institution, it does limit their generalized. Just the paper's conclusions, but a more selective or stratified approach to enoxaparin thermal prophylaxis protocol for VTE was associated with decreased rate of wound hematomas without increasing the rate of postpartum VTE. and certainly a topic for discussion as we all revise our postpartum anticoagulation guidelines.
Can you remind me the dose of enoxaparin they use?
They use BMI under 40, 40 daily, BMI over 40, 40 BID.
And it started postpartum day one.
Yeah. Postpartum day one,
So they did not acknowledge the limitation of selection bias, or what happened with the other group, with the other 1,000 patients that did have had prophylaxis but didn't, and how much was the rate of thrombosis in the same period of time? Because I don't know if the selection will actually increase the overall thrombosis.
It's a little bit weird because it's with only 4 cases that they didn't talk about the 4 cases,
right.
you know?
acknowledge the.
They didn't.
Also, what is the severity of the wound bleeding? Did they do like hematoma 1 centimeter versus
They did
open wound
classify,
back to the operating room, transfusion for the
Well,
wound?
transfusion was different.
Transfusion was different, yes, but like, what is the character? Are you going like a coin size hematoma, a hematoma case or not?
they were specific about how they defined, their,
It just was superficial or deep. I don't
Yeah,
think they had a
superficial.
size.
yeah, you're right, it was just above the fascia or below. And then they were more specific about how they defined the, postpartum complications. It was like cellulitis, fasciitis, deep intraabdominal abscess, seroma, dehiscence, hematoma. And then they defined unplanned surgical procedure as well, but we didn't have size.
So I think in, like, the first thing I always think about it when I'm like critically evaluating an article is, 1, what is the study aiming to show? And 2, was it appropriately designed to show that? So what were they aiming to show?
They wanted to look at the rates of wound hematoma.
Right, so I think that's like an important first point, is that they were not looking at DVT risk.
Mhm.
They were looking at the rates of hematoma. So
Yeah.
you gave nobody Lovenox, right? You would have a lower hematoma risk. That doesn't mean that's what you should do. So their primary outcome was wound hematoma, not DVT. And then, so the second point, do you think this was designed well to demonstrate, was it the appropriate study? Did they do a, well-designed study to evaluate that outcome?
I think so. I think it is a difficult study to perform prospectively, or slash it would just take many, many years. And I think given that they had an institutional change, they were smart to look at both data sets and compare them.
So, yeah, I think it was, so they had a power calculation, they achieved their goal power. They had and so there's a few different things. So first, the one is power calculation, they achieved their power. The other thing you want to think of is, how is this outcome defined? Is there bias in the outcome definition? Before, when you're looking retrospectively and collecting data versus then deciding to collect data prospectively, do you find things like that? So their outcome definition is not as clear as I would like. Like, was it just what was documented in a chart? Or did they prospectively call everyone or have everyone be seen in the office, right? And make sure that they had follow-up. Like if you never had a postpartum visit, you will never identify a hematoma. So that kind of data I didn't see, so they don't account for missing data essentially. There could be missing data. That's not accounted for. So that is one of the limitations in interpreting their primary outcome data. And then, the biggest balance everyone's thinking about is VTE risk, right? The reason we give thromboprophylaxis is not for wound hematomas, it's for reducing DVT risk, and any kind of bleeding as a potential risk of thromboprophylaxis, of medical thromboprophylaxis. So they didn't provide any kind of power calculation for detecting a reduced risk for thromboprophylaxis. And so I think it's difficult to make a conclusion about that. To the point of how would you design a trial, or can you design a trial? So I agree with you that I think it was a little bit dismissive. People use Lovenox postoperatively because of randomized trials, these are done.
So there are 5 randomized studies.
Yeah, like it's,
on this.
right, it's a rare
Oral-
population for everyone.
Yates published.
Yeah, no, published, it's.
Yates, Roger, London this year. The problem is their sample size is 76, 141, 25, 37, and 77. And the last one, this one by Blondon, which I thought was really well done, talks about the fact that they had about a 23% acceptance rate. And so it could be done. The issue is, so I'm a little disappointed, like, it's 0.1 versus 0.1. So VTE risk didn't change. But to show a change, so it would have to go from 0.7 or so, you need to have like 100,000. So I like to say, but there are 145 million births in the US, and this applies to most of them, and 30 million C-sections. So I actually think it's a randomized study that could be done. Many people say the same thing in the literature, and the pilot studies, most of them say it actually, it just would be.
Yeah, and you would design it differently, right? You're not designing it to show a difference, you're designing it to not show a difference. So that's a specific kind of study design that's called a non-inferiority study. Another way to do this, where you're not individually randomizing it, and especially when you need these kinds of numbers, a common approach is something called a cluster randomized trial. So you enroll, the 20 sites that are in the MFMU, that's how many million deliveries. And they're randomized by cluster, meaning like
over 100,000 deliveries a year.
Yeah, so cluster randomized means that each site for a period of time will do one study protocol and then change to another study protocol. And what you start with is randomly assigned, and the order in which you change it is randomly assigned. So that's what the clusters are. But it keeps you from having to do this kind of individual randomization, which would take a very long time, and is not really the right approach for comparing a protocol, right? You're looking for this is like a protocol that's going to apply for everyone, then you don't need to individually randomize people. You are you're comparing the implementation of two protocols. And so this could actually be, I think, very well studied with a cluster randomized non-inferiority trial across like MFMU sites. And I think it would be easily adopted. Everyone's being treated. You're treating the highest risk subgroups. It's unclear if there's benefit in treating lower risk subgroups. So I think it would be acceptable. So yeah.
I think another way I see this, I like this study, like again.
It's great. No,
there isn't 100,000 randomized study.
This is the data we have.
What I learned is that we're really worried because there's a 10% of the people who die in the US is from VTE. So something like we're like, oh, let's give more heparin, Lovenox, etc. But I think the data from this and many other things is that we don't really know who to give it to. And we may be causing harm. The UK showed the same thing on a national level. They implemented many years ago more aggressive, like let's give Lovenox to every C-section. And then there's lots of wounds. So sometimes more, it's not necessarily better, especially if, and everybody, if you look at, our thing versus ACOG versus WHO versus whatever, everybody's a different, like versus what they're doing, everybody's a slightly different risk factor criteria.
So many risk factors. Yeah.
It has to be very confusing.
Ryan, I'm wondering what our wound hematoma rate is. I'll say I see plenty of wound infections. I don't remember the last time I had a patient with a hematoma.
I only seen the catastrophic ones.
Right, that wasn't on profile. I've seen them on therapeutic.
Were because the dose was given too soon.
And therapeutic dosing.
And it was a massive abdominal wall hematoma. Many years ago, it didn't even end up in medicine somehow because of the hematoma, because renal problems. And it was catastrophic one, that the whole abdomen was purple.
Yeah, but that was also she had gotten therapeutic dosing also. So it wasn't prophylactic dosing.
I don't know if you know, but I myself got a humongous hematoma after my surgery, and I had to be transfused because of that.
Oh my God.
But there's also, I'm sure, a lot of hematomas that are
like undiagnosed, like why would somebody, like small hematoma,
So
like
much
T-cell,
pain.
Like someone.
I had
Yeah,
a
that's what I was
patient
wondering
came
about
from
more,
back,
like,
And then they're like,
but
oh,
it
there's a
seems like
small
this is
hematoma
like
there.
something that's. My assumption is, since they didn't describe prospectively looking for it, that it is
Yeah.
clinically significant
They
and
were-
that it was
they were
identified
treated.
and coded
Yeah,
for.
exactly.
Which you wouldn't, I mean, no one's trying to code for complications after their surgery, so like.
There are several points to evaluate in thromboprophylaxis, is who to give, when to give, how much to give in low-risk populations, high-risk populations, and there are so many questions. I like this RCT, they look at high-risk population, and they're looking at a standard dose versus lower dose. This come from the Netherlands. This is women who have had history of DVT, so they use weight-based versus a standard dose for everybody, and they found no differences in their outcomes of DVT and wound.
How many?
The sample size is not too big. They randomize 1,555 to the weight-based and 555 to the fixed low dose. Because this is a high rate population, the DVT was 3%. And the wounds was bleeding 4%. But there was no difference between the two groups. Meaning it's just there are many ways to look at the problem. But I think probably I think there is another one I saw last year that lower dose also did a good job with less wound in hematoma.
With the pendulum is definitely.
Yeah.
10 years ago, let's treat more.
Yeah. Like
You know, it's so
lower dose.
interesting, because in peds, it's the opposite. When it gets, it's very uncommon. Thromboprophylaxis is like a minority of peds ICU patients and NICU babies, and now they're trying to increase it, because that's a big complication that they see in their critically ill patients.
When I ran last time, so we noticed that our protocol says for women in antepartum with high risk, especially BMI, start the Lovenox admission day 3. I was wondering why at day 3. That's our protocol, and that's up to date.
Oh, antepartum.
Antepartum.
Oh, yeah.
At day 3, but they've been lying in there non-moving for 3 days already.
Yeah, I actually think that's okay, because so many people are a short-term, it kind of stops that short-term admit where someone's walking around or they're there for 24 hours.
Like our
and
people
go home.
make this thing.
And for PPROM, that's the one that's at risk of delivering in the first 24 to 48
And then they
hours,
risk
so.
of bleeding if you are on.
Yeah, exactly. So I think that's a good safety catch, that you're not, the default isn't to give Lovenox within a period where either someone could go home or be delivered. Right, exactly. Yeah, no, I definitely agree, it's a great study. It's more just for you guys to be thinking about, if this is something I want to study, how can I do it? And then I didn't do this, but I think you could take the numbers and see what kind of power they had for non-inferiority. In general, like, just like, again, the way I think about things is, if you have less than 10 cases of anything in a study, it's hard to like make big conclusions about effectiveness or lack of effectiveness or safety, even like if so.
Still,
Yeah.
it's a very good number of cases. Thousands. We will never accomplish that number. I mean, we
Not
had
at our
10
single
years.
site, but that's just like, I think I really want to push that we shouldn't really be thinking about doing things just in one hospital. Like, there's Epic, there's networks, there's enterprises, like your brain shouldn't be limited to like, we have 2,000 deliveries and what can I do with that?
Great.
And we have friends everywhere, right?
Yeah, lots of friends. Thanks, Sophie. That was
Great
important.
selection.
So important. Wonderful study.
Yeah.
Topic.
And definitely one of the things, I think, I don't know if you emailed Ryan, just to see what our, what our hematoma rate is, because if it is whatever percent or higher, then we should be thinking about it. What was it, like 7% to 3% or something?
Yeah, it's just adopted.
Yeah. No, but I mean,
I know.
So it's definitely worth thinking about.
Unless we have something else,
Yeah.
suggestion was, go ahead, Rupesh.
Well, I think you can finish, because you're in the middle of a lecture, so you finish C-section, and then I can do my research lecture either at 12 to 1 tomorrow or 2 to 3 tomorrow. I'm at Jersey, and there's like no patients from 2 to 3 randomly. But I'm happy to do it either of those times. You guys just tell me when it works for you.
Dr. Volek, I'm